So a lot of folks ask me, especially mental health providers, chaplains tend to get it, but mental health providers ask me, why, when we've got all these good treatments for PTSD, why would you start developing like spiritually integrated care for PTSD? Because the dropout rate for PE and CPT is around 39%, and only 11% of our veterans who need them darken our doorway to get them. I always joke around the exposure therapies. They are effective. They save lives. They're good therapies. We need to offer them. They are the colonoscopy of mental health procedures. Nobody wants to do that. Basically, with something that my veterans are willing to do. You look like you had a question. Oh, no.
It's true, though.
No, they don't want that.
They don't want that.
They don't want colonoscopy.
No problem.
One of the things that I learned talking to my veterans, the PTSD treatment. And one of them is I don't want to talk to people whose first name is doctor. When I was in the military, the only people I could trust, their first name is Chaplain.
I hear that.
So my team started working on what can we create that chaplains can provide to get the treatment where the veterans are willing to get it.
Exactly. Yes.
So that's what Building Spiritual Strength was designed to do. Dropout rates are a lot lower. So here's what we've done with the research. The first study, we had psychologists to do it as spiritually integrated care. Got good results. The second study, I really wanted to be able to prove that chaplains could do this. So the second study, which is a much bigger study, we'll talk about it some more, I had only chaplains as group leaders. Chaplains adhered to the manual at a 95% rate, and the outcomes were better than the psychologists. So why do we deal with spiritual distress as an adjunct to PTSD? And the literature on this has burgeoned since I wrote the slide. One, there's cross-lag analysis research that shows spiritual distress at time 1 predicts PTSD symptoms at time 2. PTSD symptoms at time 1 do not predict spiritual distress at time 2, which means spiritual distress is the driver.
Right.
So that's one of the reasons that's why I do the research. I don't just practice because of this. People who lose faith in the context of trauma need much more mental health treatment than those who are traumatized and they keep their faith intact. We're talking 20 years less treatment.
Wow.
Montana and Rosenbeck, 2004. So there is increasing research. I'm not going to give you all the citations off the top of my head because now there are too many of them. Whose spiritual distress is associated with more PTSD symptoms, more severe PTSD symptoms, more persistent PTSD symptoms. And I've already talked to you about the level of suicide risk. So when people ask you, why are you doing this? There are plenty of good reasons. Here are the currently available evidence-based treatments for moral injury syndrome. And by evidence-based, I mean there is at least one randomized controlled trial. Since this is primarily a chaplaincy audience, the two that are in scope of practice for chaplains, unless you've got another degree in mental health, are the Self-Forgiveness Workbook and the Building Spiritual Strength Program. Those are both written. The Self-Forgiveness Workbook was actually designed to be self-administered, but I use it in clinic a great deal because many people, Steve came to me during the break and said, sometimes these coping emotions are off-ramps to avoid. A lot of my folks come to me, I give them the Self-Forgiveness Workbook and I tell them, take it home, work through it. It's designed for you to do it at your own pace. I've had some great results, by the way. I've had some veterans take that home, do it in 1 week and come back a different person. But a lot of my vets can't take that and do it because as soon as they try to do it, a bunch of feelings come up that they can't do by themselves. So I coach them through it. It's been tested only in civilians. There is a VA researcher working with this book right now, trying to adapt it to make it specific for veterans. There is a big randomized controlled trial, 204 people. Really good outcomes in terms of ability to forgive self and stop condemning oneself. So I do use that in my practice regularly. Building spiritual strength has been tested, like most of our manualized treatments for moral injury syndrome are tested on since 2001, or a very select group. This is actually impact of killing and more. First they had to do PE or CPT, and then they still had to be fatal guilty about that. Trauma-informed guilt reduction, OEF, OIF only. Here's the thing, the less time somebody has had PTSD, the easier it is to treat it. There is like the neurons start to really bind with each other after 10 years. There's a real big difference in prognosis. BSS is the only one that used all military cohorts in all the studies. So we would work with the Vietnam veterans that these other studies didn't want in their samples because they're harder to treat. But we have completed 2 randomized controlled trials, which many other adaptive disclosure has now finished their 2nd trial, and they very recently published it, and I'm actually a co-author on that one too. But BSS has finished 2 trials, and we have 2 going on right now, one in VA and one in Department of Defense. So it's really one of the most studied interventions out there. What we found in both trials were there were sharp reductions in symptoms of PTSD and sharp reductions in symptoms. So I will tell you a little more about that. This is a useful resource if you're in a place where you have a choice between a bunch of interventions. This chart can help you narrow down which one is going to work for your client. So first pilot study, this was back in 2005. I was a lot younger than I am now. Little study, we had only a tiny little bit of funding. So 56 people, some went to the waiting list, some went to BSS. After the folks who were in BSS were done, the people in the waiting list went to BSS. So we had 2 kinds of control group, the people who weren't in the group at the time, but then for the people who were in the control group and then went to BSS, we had what they were doing before they were in BSS and what we had after BSS. So we had 2 studies in one. We found that there were improvements in PTSD, depression, increases in positive religious coping. There were also some improvements in forgiveness and self-forgiveness. One of the things that had me really excited, and I haven't yet been able to replicate this, but I'm not giving up, the outcomes for Latinx and African American veterans were better than the outcomes for Caucasian veterans. Most of our treatments are not written to be culturally sensitive for many of our minority veterans. And my African American and Latinx veterans would come to me and say, the way you talk about this makes sense to me. I've been confused since the day I came to the VA, and I told them I was having spiritual distress, and they sent me to some doctor who gave me medicine to shut me up. Right. Yeah. So that's what we learned in our study. The second study, Bristol Myers Squibb Foundation gave us a big pile of money to really do a much more rigorous test. This is the one where we used only chaplains, much bigger sample. And this time, instead of a waitlist control, we used an evidence-based group therapy for PTSD as our control group. So if it was going to work better than even if it just works as well as the other evidence-based therapy, you've got something that you know is useful. Unless you love research, I'm going to skip this slide. This is a bunch of research methods gobbledygook. If you want to talk to me about it, you tell me so. But here's the sample that we had. The thing that I want to point out about the sample is actually this little corner. Hey, I almost took out my lined up. That little corner in the bottom. We were collecting data in the Minneapolis-St. Paul area of Minnesota, but look at the amount of spiritual diversity we got in the sample.
That makes sense. I'm from Big Lake, Minnesota, before we get to Texas. My parish is in St. Paul. So that looks like Minneapolis. St. Paul.
Yes, it does. We asked at the end of the protocol, did you at any time feel like your religion wasn't respected? Nobody said that they had a problem with how their faith was treated. Results on PTSD, building spiritual strength is the red line, present-centered group therapy, the other evidence-based therapy is the blue line. I apologize if you are colorblind. No statistical difference in how effective both were for reducing symptoms of PTSD. Now, let's take a look at spiritual distress, which is really what BSS aims to do. So we used the religious and spiritual struggle scale. It's got 6 subscales. Are any of you guys familiar with it? Okay, if you were, I was going to say you have a bunch of yakking. 6 subscales and 6 different kinds of spiritual distress. So the real take-home picture is in that top left-hand picture labeled divine. Divine distress is distress in relationship with one's higher power or ultimate value or what one considers sacred. It is, of all of the different kinds of spiritual distress we know how to measure, this is the most potent predictor of suicide. The red line in this case is the building spiritual strength group. The blue line is the present-centered group therapy group. That midpoint is end of treatment. And the third point is a 2-month follow-up. So people with building spiritual strength came in, it wasn't statistically different, but they came in with a lot more spiritual distress than the control group did. By the end of treatment, the amount of spiritual distress had dropped a statistically very significant amount. But here's the fun thing. We quit talking to them at that point. They were all on their own. We got in touch with them 2 months later, and they had less spiritual distress than they did when we left them. They had learned some coping strategies and were moving them forward and working with them. They were getting better.
That's
Control group. Over the treatment, over the 8 weeks of treatment, their spiritual distress got marginally worse. The 2 months after we stopped talking to them, it actually accelerated. Now, this opens a question that nobody will ever let me do the research to answer because it's too politically unpopular. With secular treatments like PE and CPT, if we are not dealing with the spiritual issues, might we be addressing one risk factor for suicide, PTSD symptoms, with the same, making a number of ones? We don't know, and they're not. I am not going to go through what an eigenvalue is or anything like that unless you,
Price control helps.
Okay. All right, I will.
The number 1 question in all health is what really matters to you.
Exactly.
Okay, that might be something I can do.
Because then the people will tell you what matters to them, right? Then you're not asking the question with a loaded weapon, right?
Right.
Instead, you're letting them do a write-in, right? You're simply saying, hey, what's bothering you? And then, like my fellow priest has said, hey, now they're telling you what's bothering them. And you don't have to upset anybody, you're just letting them speak for themselves, what they want anyway.
Why is it too politically? I don't understand. Why wouldn't they?
Oh, because
I mean, honestly, because it's the VA.
That's the nonsense that they, what you got there.
Very little, very
And
little.
that's that.
Yes.
If you dare do it while we're there.
In the current administration, in certain states.
they're all funded. So here's the thing. PE and CPT, prolonged exposure cognitive processing therapy.
Oh, I know it.
Yeah, the VA was like struggling treating PTSD and people weren't getting better and all kinds of resources were going into that until PE and CPT. It made the lives of administrators at VA much better because those therapies work well if you go into them and you stay in them.
Those are big words.
And
Exactly.
So they're fully invested in.
Challenging PE and CPT is not going to grant funding.
Yeah, that's right.
It's just not going to work.
What if you added 2 other therapies? So you were looking at 4. So
Yeah.
it doesn't look so.
Yeah.
Something.
Someday I will figure out a way around it. I haven't yet, and it's easy to go through doors and walls.
Tribal health, I think
I will.
that's your avenue right now, because they're still funding that pretty substantially.
Yeah, they did just give a lot of funding to a chaplain scientist in my lab. So.
Research chaplains, yeah, that's what you're waiting for.
Okay, correlates of the divine distress scale. This is worth talking about. The divine distress scale predicts more depression, more anxiety, more anger, and more loneliness.
Mhm.
It predicts more presence of meaning in life. I'm sorry. It predicts less divine distress, more meaning in life, more life satisfaction. Now, when you look at that constellation of symptoms that are related to divine distress, how different is that to the symptoms I put up on the screen earlier that were symptoms of moral injury syndrome?
Almost an overlay.
Then that pretty closely. So at the time we did this study, this was in 2013 to 2018, we did this study. The two new measures of moral injury syndrome were out. That was the closest we could come to measuring it. All right, so end of research section. There weren't any statistical differences between the effectiveness of BSS and present-centered group therapy, which is already an evidence-based therapy that the VA uses for PTSD. BSS was much more effective in treating spiritual distress. To date, still, even though this was published in 2018, I think this is still the only study of a treatment for moral injury that looked at spiritual distress as an outcome symptom. I see that face and share that sentiment. Because BSS is based on this theory that psychospiritual development drives moral injury, this tells us a lot of we need to study psychospiritual development, which is why we need chaplains, which is why I employ chaplain scientists in my lab and I don't come here without a group. Okay, so now we are going to go to techniques and foundations. Lunch is not far away, we just had a break. So can we just take a collective? All right, we're going to change topics now. This is everything I have told you thus far is why. Why would we do BSS? Why might we do it in the way we're doing it? The rest of today is how. Okay. So here's what goes on in the 8 sessions. How many of you have done group therapies, group counseling before? Okay, bunch of you. Session 1 is the same as session 1 in every other cohort-based group we do. Here's what the group's about. Here are the group rules. Let's introduce ourselves to each other, establish some rapport. One of the things I invite groups to do, I do not require them to do, is I invite groups, if there is a ritual that everybody in this room agrees is meaningful, to set apart this group as sacred space. We can practice a ritual at the beginning of end of every session, however you like it. It forces people to start to work with each other's perspective to figure out what would be meaningful to everybody. And we're trying to make people look at things through multiple perspectives at the same time, every session, as often as we can, as hard as we can. This is the key to getting from Fowler 3 up to Fowler 4. So that's session 1. We learn about the group rules, and we establish rapport and get to know each other. Sessions 2 and 3. These are the hard sessions to do. They're the hard sessions for the therapist. The techniques can be a little scary. If you're used to practicing cognitive behavior therapy or acceptance and commitment therapy, when you walk into session, you know exactly what's going to happen in that session. You know what you're going to talk about. That does not happen in sessions 2 and 3. You know the structure of the conversation you're going to open up. You don't know who's going to say what. For many, especially mental health providers, it is as though they have been asked to step on the water. They are scared. But it works really well. And I've got some unpublished growth curve data that shows that these techniques are what makes the difference in building spiritual strength. And we will practice these techniques every session. We'll also spend a lot of time practicing them here today. Sessions 2 and 3 are, I joke around and say that this is marriage counseling in your relationship with your higher power or your ultimate value. It establishes some kind of communication relationship. A veteran, I'm not going to tell the story because we don't have that much time. Theodicy. You guys know what theodicy is, right?
Yes.
Okay, not everybody. So theodicy is this issue. They tell me there is this all-powerful, loving God who can do anything it wants and it loves us. How can this crap happen? That's the issue of what theodicy is.
C.S. Lewis said the problem of pain.
That is a nice way to put it.
The problem
The
with
problem of pain. It's a book by C.S. Lewis. So,
That's very good.
Okay, so that's session 4. Session 5, so the currently released BSS protocol. Session 5 is on meditation and prayer coping strategies. There's a BSS 2.0 that we are using for 2 of the current clinical trials. That is really, instead of the prayer coping strategies, it broadens it to spiritual practices that help us with coping. So it gets into mantra meditation, practicing self-forgiveness, journaling, gratitude, etc. In my own practice, I'm finding that it works better. The growth curve analyses were telling us that session 5 was not being helpful. It wasn't hurting anything. So if you want the new manual, there is not the evidence so much for that session 5. But if you want the new manual, I will get it to you. Session 6 and 7 are on forgiveness. And then session 8, how many of you are familiar with the phrase consolidation of gains? Okay. For those of you that you know what this is, if you just haven't heard that language word, I go through therapy. I make some huge changes. I'm doing things really, really different at the end of therapy. If I do not say out loud in front of myself and my therapist and my family and the other members of the group, if I don't say, I can go to the grocery store at 4 o'clock on Friday now, and it doesn't bother me how crowded that is. I can walk into my church and not feel like crying now and make friends there and connect with my community. If you don't make these I can statements, you do not incorporate that progress into your self-concept. And the family that is used to that person not being able to function will continue to expect that person to not function, and they'll go right back to not functioning. So session 8 is the I can do this now, folks, and reflecting to each other. This is what I see you doing now. It allows people to incorporate what changes they've made back into their self-concept. So those are the 8 sessions in quick review. A lot of having a successful BSS program has to do with what you do before you even bring those veterans into the room. So first of all, I've told you this slideshow is largely about mistakes that have been made. I once had a setting where they put a BSS group in an involuntary inpatient setting. There's lots of places where BSS is being done in inpatient settings where people are very, very clear with the nursing staff. This is a voluntary group. I know that patient may be inconvenient for you, but this is a voluntary group. You cannot force them to go into this group. That's got to be clear. This particular station had a belief that everybody had to come to at least the first session to see what it was about. There is no such thing as involuntary spiritually integrated care. It's not ethical. Don't do it. If you are doing it on a domiciliary or an inpatient unit, etc., the staff needs to be educated. This is not a required group. People don't get demerits for failing to attend it. This has to be voluntary.
it's a PRG, personal recovery.
Yeah.
Okay.
Yeah. People ask me a lot. I've got a veteran who's come into my group who's atheist, agnostic, religious, non-spiritual, but not religious. How do I work with this veteran? So let me start back. Study 1. I had people who identified as atheist and agnostic signing an 8-page consent form saying, I want spiritually integrated care. I'm going, can you tell me, tell me more about their interest in building spiritual strength. And they would range widely. One was, I grew up Catholic and I loved it. And I can't make any sense out of it anymore, but I'd love to get it back. Another one is, I've tried everything else. Nothing else works. I'm desperate. Sometimes it's, you pay me $200 to be in the study, right?
Yeah.
But yes, they do come to us. So let me share some tricks and some inclusive language that works. If everybody in the group has a higher power language works. Unless it's, I believe, the Church of God in Christ that had a number of veterans. They don't want the higher power language. They want G-O-D written in their book. And we have a version for those folks. All of the other versions I use higher power. But for my atheist and agnostic, sometimes higher power makes sense. Like usually I will ask them, when you are out of options and desperate, where do you go for support? And for example, I had one veteran who used to tell me the voice that comes to me in my truck. He was an over-the-road driver. He did not identify that voice as God, but he knew when he was in trouble, if he listened to that voice, it would work for him. Others don't have like an anthropomorphized relationship that they can work with. And so for those folks, I use the phrase ultimate value. What is your relationship with your ultimate value? Do you have the kind of relationship with that value that you want? It's very similar to, I ask veterans when they come to me with substance use problems, what's your relationship with alcohol like?
Mm-hmm.
Is that relationship what you want it to be? So I talk about an ultimate value in that way. If I extend my inclusive language that far, I have not had a place where somebody who was atheist or agnostic told me, okay, this didn't make sense to me. If you're in a public health setting, a lot of us in the room are from the VA. There are some ethics issues that you've got to talk about, and you've got to make sure that your colleagues talk about. Most people are really good about talking about this with their veterans, but it's really important that colleagues know if they're going to make a referral to the group, what the group is. We do not proselytize. I have had veterans with traumatic brain injuries who come from denominations that believe strongly in evangelism, who were horrified that they couldn't proselytize in group when I had the individual meeting with them. My response that has always worked has been, first of all, if evangelism and sharing the good news is a basic tenet of your faith, you should do that someplace else. That's the appropriate place to do that. The other thing I tell them is if your relationship with Jesus is helping you to recover, rather than telling other people that, if you show them that in your working group, that will do more to share the value of your faith with them than anything you could teach them. Mm-hmm. And with that, most of those folks are able to do that.
So can you flesh that out for me? Like, people are naturally going to mention their faith. How is that not considered?
So it's fine to talk about your faith in BSS. It is not fine to bring your flyers and hand them out and say, everybody needs to come to my church because we are the right one.
Okay. Or you gotta help.
Right. Yeah.
The distinction that's made there in terms of proselytization being the difference between talking about your faith as part of your overall coping structure versus an attempt at conversion.
Right. Yeah. That's a really good way to put it. Thank you. The chaplains are experts in talking about it.
Yeah, all right. Tell people all the time that there's a conversion, the Holy Spirit does it. He doesn't need you to do it.
I love it.
Yeah.
I love it. One communication problem that often happens, the best way, not the only way, but the best way to do BSS is chaplain and a mental health provider together. What?
I said that's wonderful.
I love doing it. I love working with chaplains. Here's a thing though. There are some cultural differences in how mental health providers and chaplains are trained. Everybody does role plays to learn counseling techniques. Chaplains, for the most part, are trained to use their own stuff. Mental health providers are trained never to use your
Right,
own stuff.
right.
Chaplains are trained that use of self and making your own life an example is your go-to first line counseling interventions. My particular discipline is the most, I don't know whether to use the word phobic or paranoid discipline about self-disclosure.
Yeah.
So it's not unusual. I always tell people, you're starting a BSS program, you're up in the road, get hold of me, talk to me, I'll help you. I get the call from the psychologist. The chaplain is using self-disclosure in every session. Like, okay, is the chaplain using self-disclosure to do something to help the client, or is the chaplain using self-disclosure to do something to help the chaplain? Oh, they're doing it to help the clients. Like, this is just a discipline culture.
That's what they.
It's okay. You don't have to change your practice. You let a chaplain be a chaplain. They know what they're doing.
Yeah, I love that. I love that.
I think that's changing a little bit. There's some really good research out there now about self-disclosure. If it's point driven,
Yes.
it's brief,
Yes.
and then it elicits because the person will feel more connected to you
Right.
and will not
Right.
see you as some, you know,
Yeah.
extra or whatever. But
Yeah,
I think that in, you know, the profession of psychotherapy is changing, but not ad nauseum to talk
Right.
about yourself, right? That's
Right.
different.
There's some other research that I'd love to talk to you about that. So I'm not going to tell that story. A lot of times people will say, especially in VA, this is a federal facility. How can you be doing spiritually integrated care in a federal facility?
Free exercise of religion.
Free exercise of religion.
Texas.
The Joint Commission, the Joint Commission that accredits hospital says that we have a requirement to provide spiritually sensitive care. You've
It's
seen
not
research
religion.
on the
it's not religion, it's
it's
spirituality.
spiritual. And we're not teaching a religion in BSS, we're helping people sort out spirituality. So the Joint Commission requires we provide spiritually sensitive care. Given the volume of the research literature on the relationship between spiritual distress and PTSD, we would be ethically
Yeah.
remiss
Right,
to fail to provide that kind of care.
absolutely.
My ethics code as a psychologist says I must consider religion as an individual difference if it is relevant to the presenting problem. Again, piles of research demonstrating the relevance. MDs, nurses, social workers, all mental health disciplines have an ethics code that tells them they either have to consider religion or culture as it's related to the presenting problem. Religion is a piece of culture, so all of us have ethics code that basically say we need to be able to provide this kind of care. So when people come to you and they're making that challenge, you now have all you need to address it. Also, call me if you're having trouble getting through to people do that all the time. So let's talk a little bit of scope of practice. If Drew and I are sitting and leading group together, here's the deal. I will not define the nature of the higher power. That is Drew's job. I do not touch sacred text. There is nothing in my PhD programming in psychology that taught me how to interpret sacred text. I know that it's complicated. I know that I'm not good enough to do that. One of the places I often go to chaplains to ask help is, are this person's stated beliefs consistent with their stated faith identification? Sometimes that's the difference between a diagnosis of a psychotic spectrum disorder or not. And there have been lots of times I have made emergency calls to veterans and got a Southern Baptist here who says that God intended that he should have died when he was shot off the communications tower and now feels that he needs to fulfill God's will. And chaplain's able to tell me, no, that's not coming out of his Southern Baptist church, going to be through the inpatient unit. On the other hand, there's things that the mental health providers do, like we are experts in relationships. That includes relationships with a higher power. I can talk about the impact of depression and PTSD on your relationship with your higher power. and help to troubleshoot where depression and PTSD may have an agenda to try to remove the help of your higher power from your life because it makes life tougher. I can talk about that. I am the expert in education on PTSD, psychopathology, depression, anything in that area. I'm not saying chaplains can't do some of that, but I've got more training in that. And I brought up the issues with self-disclosure already. So this is where the fun part starts, where we start doing instead of just, yeah, man, I'm sure you guys are okay. We don't know. How do you know during the individual interview, somebody's been referred for BSS and you need to decide if they are appropriate to be in a BSS group? So who's appropriate for BSS? One, they need to be safe. It's group therapy. A suicide in the course of a group therapy does not help anybody in that group. It's a problem. People have out of control anger if they are regularly assaulted. This is not good to have in groups. So they need to be safe with regard to self. If they're not, we're not saying you can't get treatment. It's just you need individual treatment, not for treatment. Substance use. So here's the deal. I do not say if you're using, you can't be in BSS. There are a lot of people who have substance use concerns that find BSS extraordinarily helpful, because at the same time that they resolve the spiritual distress that's hanging up their PTSD recovery, they're resolving that issue with their higher power that's hanging up their 12-step participation. So a lot of times it works really well for people who are managing two kinds of recovery at the same time. So here's the question I ask. The first question is, I look at the notes and I find out, is this veteran's report of their use consistent with their labs? Are they being honest about their use? If their report about their use isn't consistent with their labs, they're not ready for BSS. They have to at least be able to report on their use accurately. The next thing I ask is, if they are able to report accurately on when they're using, when they're not, etc., can you come to group clean and sober, and can you do your homework clean and sober? Because they're not going to benefit if they're not doing those things clean and sober. The neurons are not going to remap if they're high or hungover when they're trying to do that. So if they tell me they're a reliable reporter and they can tell me they're going to do group and they're going to do their homework clean and sober, I'm good with them being here. They need to be able to respond appropriately in these social situations. Again, these are mistakes that I've made. I had a good friend of mine say, I've got a client who is dealing with a morally injurious situation. He's managing bipolar disorder. I think he would benefit from the group. It took me 90 minutes to do his intake interview because he kept going off on tangents. Guess what he did? If it hadn't been like my good friend who referred him, I would have said no. But she's like, he's been in group before. He's benefited from group before. It was a nightmare. I could not get him corralled back in the group. I eventually had to remove him from group. So I am not saying psychotic spectrum disorder means you can't be in group. Most people who manage psychotic spectrum disorders, the types of treatment and rehabilitation we have available today, are functioning as well as I am right now for most of their lives. They'll have episodes where they're not okay. So it's not a psychotic spectrum disorder, that's the distinction. It's, can you be socially on track and be with the group, or you're going to be off in chasing the delusion land? That's not going to work. Does that make sense? Along with these criteria, you need to provide in that individual interview some basic education about the group, what you expect, etc. Does that make sense? Yeah. So Drew and I are going to do a role play, an intake interview.